Bismillahirrahmanirrahim. This is Dr. Ghufran Babar, a physician in America, and you're watching my YouTube video. Today's topic is very interesting, and it is constipation in babies and children. So, constipation is a passage of either very hard stools or infrequent stooling, and is a source of concern for children or for parents, and of course anxiety and concern for children as well, affecting their behaviors and their lifestyles. So in normal babies at birth, they pass the stools, which is called meconium. Up to 87% of babies, they passed stools within first 24 hours of life. Up to 48 hours, 99% of normal babies have passed their first stool, which is called meconium. Subsequently, the passing of stools is variable. In neonates, there is a reflex which is called gastrocolic reflex, in which when the baby feeds or a child eats food, a wave of peristalsis goes down through the intestines into the large bowel, large intestine, rectum, and the rectum, and the baby passes stools, which could be after every feed or could be up to 5 times a day, and in sometimes once every few days is also considered as normal. Babies who are breastfed has whey protein, so their stools are softer and maybe more frequent, versus cow-based milk formula has casein as protein, so they may have firmer stools. And formula-fed babies their consistency also depends in the fat content of the formula. And by 16 weeks of life, most babies pass stools about 2 times per day. And once they start having semi-solid food around age 4 to 6 months, then their stools become more firm, and the consistency gradually increases. Usually in babies or in old children, they have an internal sphincter which is involuntary, not in their control, and an external anal sphincter which is at the anus is voluntary, is under control. Passing of stool, not passing of stools, or continence is combination of sensation of stools in the rectum, and then motility of the colon and rectum, and good function of their sphincters. And in babies, these sphincters, the voluntary control is not that developed, so that's why as soon as their rectums are full, most of the times they will pass stools. And presence of feces or stools in the rectum causes a decrease in tone, first in the internal sphincter, and that also causes urge to defecate or pass stools when it comes in contact with the lining or mucosa of lower rectum. And if the older child has control on the sphincter and they don't want to pass stools at that time, the external sphincter closes, and same happens when adults, by the sphincter and the gluteal muscles, the glutes, which are muscles in the back of the pelvis or the hips. And when they want to pass stools, the position is appropriate, the situation is appropriate for older children, that relaxes they relax external sphincter, and they are able to pass stools. So In younger babies, like I said, it depends on their type of formula and whether they are breastfed and their normal variability. So a lot of times, some studies have shown that they may not pass stools up to a week, but as long as they are feeding normally, that is the key. They're not having vomiting and they're passing the gas, then and they're passing the urine, there's less concern. So not passing stool every day is not required for the babies. They may stool every 1 to 2 days or every third day. So that is not uncommon in the babies. But the most important thing is the child is thriving, gaining weight, passing urine, has no vomiting, and doesn't have any excessive fussiness or crying. And babies, they usually are laying, so they are not in a squat position. So for them to use their abdominal muscles, which are already weak, and they have to really move their abdominal muscles, as well as usually in defecation, they take a deep breath in, which lowers the diaphragm, increases the intra-abdominal pressure, and they contract their abdominal muscles, and that is a laborious event. So they may feel, it may appear that they cry during stooling, but if the stools are not very firm, very hard, and it is happening on a regular basis, it should not be of concern. So the babies are not older children or adults, so they may not choose, or they may not, their physiology may not have them stool every day. But remember, whenever you have concern for constipation in a baby, look at the stools. If they are very hard, very firm, then you may want to talk to your pediatrician. But if the child is having no fever, drinking normally, being okay, that means their physiology is such that they may stool every other day or every third day is possible. But some babies may stool after every feed up to 6, 7, or 8 times per day. So it is the consistency which is very important. So they should not be labeled as diarrhea, that oh, the baby is having loose stools, is having diarrhea because is pooping after every feed. If it is all liquid, then you start worrying about diarrhea. Otherwise, softer consistency in stools does not mean diarrhea, or passing stools after every feed does not mean diarrhea. So if the babies and older children, they have hard stools, which are happening less than 3 times per week, or they have fecal incontinence in older children where they may just pass stools without control, or when you examine, they have large amount of stools in the rectum, and the diameter of stools is really large when the parents watch the stools, and or they have behavior which is suggestive of retention of stools, posturing, withholding, maneuvers, and it becomes very, very, very painful in toddlers and young children, then those are of concern for the parents and the physician. And the causes could be neurological, organic, or neurological problems with the nerve supply of the rectum, the anal sphincter, or functional, which are non-organic causes, meaning incontinence because of either retention of stools and no prior history of constipation. And then there could be fecal impaction, hard stools within the intestines which don't want to come out in older toddlers or children, or even toddlers and children. Then they will need assistance to help with their stooling, and sometimes pelvic floor dyssynergy, inability to relax pelvic floor when they're trying to defecate, can be also present. So the pelvic floor muscles, they have to be relaxed, so the sphincter to become relaxed so that they can pass stools. uh, there are a lot of reasons for children, babies and children, to be constipated depending upon the age, which could be lack of fiber intake, decreased movement in the lower intestine, loss of nerves and motor function of the lower rectum, or the anal sphincter. The longer the feces remain in rectum, the harder they become. So regular bowel habits are key to dry pass stools. Or sometimes if the hard stool is passing out, it causes a crack or a cut in the anal sphincter, which is called fissure, which is associated with blood in stools, very painful, and that causes stool withholding. They don't want to holding of stools. They don't want to pass stools, and they avoid to pass stools because the stools are so hard and it is painful. And that is kind of a snowball effect that further deteriorates the problem of constipation. And if this is not treated, the volume of stool becomes larger and larger, and rectosigmoid, they really become large, and the dilatation of hollow organ causes further effect on the peristalsis. And peristalsis is the movement of the intestines. They will further be impaired. And like I said, there could be local tear in the intestine, anal sphincter, which could be painful and lead to further fecal retention, and difficulty in passing of those large hard stools. In babies, when they are weaned, type of stools are important. In toddlers, acquiring proper stooling skills and techniques are important. In school age, they have to be supported, and most children are toilet trained by age 4 years. Constipation could be difficult to treat and needs a lot of support, explanation, medical therapy, education. So it's multifactorial treatment is needed. Special treatment may be needed in organic causes where they are treatable. A lack of relaxation of anal sphincter, anorectal pressure monitoring, Hirschsprung's disease, sometimes neuroenteric causes, spinal cord abnormalities, pelvic floor dyssynergia, meaning lack of relaxation of pelvic floor, metabolic like the hypothyroidism, hypercalcemia, cystic fibrosis. Sometimes in those old houses, children can have lead poisoning, or if they are being exposed to opiates, meaning morphine derivatives, codeine in cough syrups, or antidepressants, they can cause constipation. Cow milk protein allergy can also lead to constipation. So anatomical causes could be local stenosis at birth. There is anal stenosis that needs to be dilated. Ectopic anal opening that needs to be surgically corrected. Anal stricture, meaning narrowing of the anus, or fissure, where there's a tear in the anal area. And sometimes presacral mass or tumors can also obstruct the outflow of anus and rectum, leading to constipation. So how are we going to treat the constipation depends on the cause. If there are neuromuscular causes, mental retardation, malingominal seal, spinal trauma or surgery, tether cord, muscular dystrophy, so those are organic causes that need to be surgically treated, or supportive care has to be provided. There is a very common illness which is called Hirschsprung's, fairly common, which is absence of ganglion or nerve cells in the rectum and anal area, due to which the lack of contraction of the muscles in the intestines leads to retained stools. And or there could be complete segment which is absent aganglionosis, lack of those nerve cells, which basically elicit a nerve impulse, because the nerves innervate or nerve supply to the muscles in the wall of the intestines, after which they contract, and that contraction leads to passage of stools. And sometimes there could be obstruction of passage of feces, like I said, because of the anatomical reasons, because of the outer segment being constricted or stricture. And severity depends upon how long the segment of the intestine is, which is without any nerve cells. Other causes are once the weaning starts in the babies and toddlers, they don't have good eating habits, lack of fiber, not good toilet training, and the defecation because of the hard stools. The passing of stools or pooping becomes painful. And parents should not be too aggressive in toilet training, which can also lead to withholding behavior or avoidance behavior. Irregular therapy or follow-up is also caused, meaning that if you are involving a specialist in care, you are not getting proper care. Medications, sometimes kids could be on may have epilepsy, like phenobarbital, anticonvulsants, diuretics, sucralfates with antacids. Iron preparations can cause constipation, anticholinergic, antidepressants, cough syrups, codeine, over-the-counter codeine can, or Tylenol with codeine can cause, acetaminophen with codeine can cause constipation. And usually constipation could be anywhere from 0.3 to 28%, more in boys, 3 to 1 ratio. 95% of functional constipation, unknown cause, greater than age 2 years. And usually children who are under 5 years, they can take up to 1 year to completely recover. And 60 to 70% may recover in up to 2 years. And children who are older than 8 years, they may still have constipation in 1/3 of the children. And success can take up to 5 years. So being patient is the key, and continuing to follow your physician's instructions is the way to go. And usually in 1/3 of the people, if they stop eating healthy, avoiding fiber or medical treatment, in 1/3 to 50% of the people, the constipation can recur even when they go into puberty. So even older kids may have the constipation problem as well. Organic causes which could be treated include, like I said, Hirschsprung disease, high calcium, low thyroid hormone levels, gluten enteropathy or celiac disease, lead overload in the paint chips in old houses. Cystic fibrosis can even present with meconium ileus, retained meconium at birth, they don't pass. And medications like opiates or narcotic analgesics, codeine, barbiturates, anticonvulsants, and antidepressants. In babies, delayed passage of meconium beyond 48 hours is a concern. Hard stools are passed. Breastfed babies may have regular bowel habits. However, sometimes they can have also infrequent stooling. Weaning can make the food more stiff, especially if the weaning is foods which are low in fiber, starches. And later on, when they are doing, parents are trying to do the toilet training, stool withholding behavior can cause functional fecal retention and behavioral problems. Child refuses to get toilet trained. And if they had a painful defecation experience, so the fecal soiling or passage of stools, which is onchoporesis, 60% or 63% of cases have had a painful stool passing episode. There was a tear associated with anal fissure in which they had struggled to pass stools. So that kind of previous experience can trigger constipation. Sometimes they can have rectal prolapse because of overstraining, or sometimes with increased thoracic pressure, like recurrent coughing, disorders like whooping cough, Diarrhea can cause rectal prolapse as well. So it is important for the parents to see the stools in toddlers, see if they are hard, they're large caliber, the child has a stained underwear, and whether their diet is low in fiber, low in vegetables. Then you have to make sure that those things are corrected, and a proper timing is scheduled for the children to go to stools. They are asked to stay relaxed, and restricted access to screen time when they're stooling, especially in older children. Toilet avoidance, because they are overly busy in their other activities, has to be avoided, so that they can pass stools on a regular basis. And assessment of children, if they have developmental delays, type of foods that they are eating, so detailed history taking will be important. Local exams of the anal area should be done, abdominal exam, and then there's the MRI if you see a sacral dimple or the child is not moving lower extremities. Look at the anal wink examination, making sure the anal sphincter is contracting. Look at the cremasteric reflex. Sometimes a rectal exam to look at the anal tone could be done. Anorectal manometry, in which pressure is measured, and if there are impacted stools, that have to be evacuated by different treatments. Investigations can start after the physical exam. Plain x-ray can tell you how much stool load is there in the large intestines, or if there's obstruction that can be seen. And how big is the rectum on x-ray. Greater than 3 centimeters is profound. Hirschsprung suspicion, barium study can be done, where you can have a rat tail sign with dilated sigmoid colon, and lower portion of the rectum may be just be too narrow, like a tail. Impaired sensation in to rectal distension, those people who don't have nerve fibers. Abnormal contraction of sphincter is too tight, or the muscles are not relaxed for the child to pass stools. So radioisotopic studies are available, and most importantly, a rectal biopsy can be done, and acetylcholine esterase study could be done, or full thickness ganglionosis can be detected during the exam. And usually Hirschsprung's disease starts at a younger age, with no fecal soiling would be present. Management, it's a very, very delicate thing. In babies, reassurance, that's not a serious thing if the child has infrequent stooling. As long as they are doing stooling up to 3 times per week, that's appropriate. The child is tolerating feeds, passing urine, staying hydrated, and not big discomfort, so that is reassurance. Then you have to look at the stools for the parents and the physician. And parents, if they see very hard stools or streaking of blood, then intervention is needed. In toddlers or younger preschool children, disinfection, removal of the stools has to be done by medical or physical way. Dietary changes have to be 5 servings of fruits and veggies. Maintenance of this behavior, relaxation during stooling is very, very important. But explaining of the normal physiology, that the children will take a deep breath in, that will lower their diaphragm, increase intra-abdominal pressure, sensation of stools in the rectum, with first relaxation of the internal sphincter and then followed by the outer sphincter, which is voluntary once the child becomes old and toilet trained. And under pre-toilet trained, it is usually involuntary, and children can pass stools without any voluntary self-control. Local exam, make sure that there's no tear in the anal area, there's no bulging veins coming out, there's no prolapse of the rectum. So those are the painful things with stooling, or there is impaction that you can obviously see, hard stools not trying to come out. Sometimes laxatives and sometimes manual disinfection may be needed. The hard wall of intestines stools is in the rectum, not letting the stools come out, and sometimes some amount may leak out from the sides, which is onchoporesis, which is a very difficult thing to treat, and with the children may have fecal swelling or staining of their underwear with stools, with a lot of psychosocial stress in school. So that needs to be corrected. And most importantly, explaining to the child, if it's older, to relax during stooling. Family should set up proper time to go to bathroom, making sure the child spends good amount of time passing the stools. It should not be abrupt, like passing during and then running out, and that cascade of hardening of stools in the rectum and further problem with passing stools. And the leakage of stools is not voluntary onchoporesis. It happens involuntarily. Diet-wise, excess milk intake with bottles is a lethal combination. Lack of fiber intake, like veggies, salad, fruits, they have to be at least up to 5 servings daily. Avoid junk foods with low fiber. Avoid non-fiber containing foods, making sure the children eat a good breakfast, drink plenty of water, and if they have hard stools, then and signs of constipation on the x-ray. Younger babies, if they have anal stenosis, or anal atresia can also happen, that needs sometimes surgical correction, or Hirschsprung's disease that may also need surgical management. Otherwise, in babies, prune juice up to 2 ounces twice a day, or apple juice twice a day, 2 ounces will help increase fiber in the increase sugar, which will cause osmotic fluid and softening of the stools, because fluid will come out of the intestines because of the high sugar in the stools and will cause softening. Younger babies, a small glycerin suppository can be given. As they get older, over 6 months, they can get Miralax, polyethylene glycol mixed in water can be given. If there are acute impaction in toddlers and preschool children, enemas can be given, and then followed by daily use of Miralax should be used, and based on the recommended doses. Saline enemas could be used with 500 to 1000 ml depending upon the weight of the child. Other thing is that if enema doesn't work and child is in profound discomfort, admission can be done, and there is a medicine called Golightly, which could be 25 ml per kilogram per hour, could be given through the NG tube. That will dissolve the stools and they'll come out. If that doesn't work, manual disinfection by hands under general anesthesia could be carried out to help the child. Treatment will depend on the cause, and slow disinfection with oral senna can be done. Magnesium hydroxide is another medicine. Beyond age 6 months, mineral oil can be used. Oral lactulose is very important, daily can be given. Make sure do not give phosphate enemas. Occasionally glycerin enemas or suppositories can be given. But the bigger things is the dietary modifications in toddlers, fiber intake, and behavioral modification, making stooling a relaxing experience when you are doing the toilet training, not pushing too much for the toilet training, because that can further delay the voluntary control and would further cause constipation. and watch the stools of the children, and persistence with the diet and relaxation techniques will cause regular stooling. And you can do regular toilet regimen 2 to 3 times per day, where they go and sit and try to pass stools. Usually it is good to have a fixed time for stooling, especially in the morning. Make sure they are sitting on the toilet seat if it is, and make sure there's a foot support with them with flat feet. There's no the party should be unhurried, and if you're training them, followed by a reward would be useful. And positive reinforcement if they pass tools. Make sure you praise them, give them a prize, and that will help with the stooling and maintaining daily stooling. Diet we discussed, and laxatives, like I said earlier, different laxatives. Mineral oil can be given in older children, 1 to 3 ml per kilogram per day, and toddler or preschool children in 2 doses. Lactulose 1 to 3 ml per kilogram per day in 3 doses can be given. Magnesium hydroxide 1 to 3 ml per kilogram per day in 2 doses can also be given. And Miralax or polyethylene glycol 1 gram per kilogram per day in 2 doses can also be given in toddlers or preschool children. But for infants, make sure it is stimulation with juice, or you can use prune juice, apple juice, hydration. And once you start weaning, make sure the baby foods have fiber in them, like spinach or fruits which are mashed fruits with fiber in them will help them stool regularly. Senna is a stimulant that can be given in 2 to 6 years of age or older. Bisacodyl is another kids which could be given as tablet form in older children, or as a liquid form. Docosate sodium, which will be helping to soften the stools. So best results, combination of medications and behavior treatment, and that will take care of the constipation. And in encoparesis, it can take up to 6 months, sometimes longer. Weaning schedules could be up to 6 months. Follow up by the physician every 6 to 12 months or sooner. And encoparesis or soiling of stools is their relapse is up to 50% of people. Most importantly, depending upon the age of the child, a detailed history, physical exam, understanding the dynamics of the family, counseling them, reassuring them, and telling them to be patient. Eventually, the constipation will go away. However, don't be surprised if there is relapse, if they stop doing the right things. And cause is treatment can also be specific for cause, like Hirschsprung's disease may need surgery. If there are anatomical problems, they will need surgery. Resection of the sigmoid, if it is too dilated, toxic megacolon can happen. Those things are possible. But early consultation with the physician, proper diet change, toilet training, relaxation techniques, thorough exam and detailed history. If you need to investigate, you're suspecting Hirschsprung disease, that has to be done. And treatment chart has to be made systematically so that the family follows those instructions, and make sure they're prepared for a good and prolonged follow-up, so that the treatment is not ended too soon, because up to 50% of children can have recurrence of constipation. Please, I hope this video was useful for you guys. Please like and share this video, and if you have any comments, please leave them for me so that I can review. May Allah take care of you and help you all and your families, and bless you all. Sallallahu alaihi وآله وأصحابه وسلم تسليما. Thank you.